Good morning. I will be presenting a dose-response relationship of intrathecal morphine effectiveness in post-cesarean patients under spinal anesthesia. Intrathecal morphine is commonly administered at a dose of 100 to 200 micrograms. However, the optimal dose for pain control with the least side effects is yet to be established. Studies have shown that patients usually complain with pain and patient discomfort with lower doses of intrathecal morphine, while higher doses comes with greater side effects. Our purpose of this study is to determine the lowest dose of intrathecal morphine that will provide adequate analgesia with minimal side effects among patients for cesarean section. These are my specific objectives. So, 60-term parturients, ASA less than 3, aged 18 to 40 years for cesarean delivery with spinal anesthesia were enrolled in the study approved by the Ethics Review Committee. The following are my exclusion criteria. They were randomized using a computer-generated table of random numbers. The dose assignments were placed in an opaque envelope that was immediately opened before the preparation of the spinal anesthetic dose. So each patient were randomized to receive a 50, 100, and 150 micrograms of intrathecal morphine with hyperbaric bupivacaine. The dose assignments were prepared by the secondary assisting anesthesiologist, and the patient, the clinical care team, and the investigators were blinded to the treatment group. All patients receive preoperative hydration with crystalloid solution. Standard monitoring was applied throughout the procedure, and spinal anesthesia with the designated intrathecal morphine dose was administered using a gauge 25 Quincke needle. The following medications were started and maintained for 24 hours post-spinal anesthesia as part of our multimodal analgesia regimen. Tramadol 50 milligrams IV every 6 hours is needed for pain, or on pain scores greater than or equal to 6 out of 10 were given and available. Data was collected and measured using the visual analog scale. The incidence of tramadol was also recorded, and the pain scores during tramadol administration were recorded and carried over to the next hour of pain assessment. Nausea and pruritus were recorded using a 4-point scale, while vomiting was recorded using the following 4-point scale. Antihistamines, reversal agents, and antiemetics were available for use for treatment of respiratory depression, nausea and vomiting, and pruritus. Scores were recorded by the study personnel at 6th and 12th and 24th hour. Data analysis was analyzed using the following parameters, and a p-value of less than 0.05 was used as cutoff for significance. For the results, baseline demographics showed no significant difference across treatment groups. For pain scores, at rest and upon movement, notice that the 50 microgram group had higher pain scores, especially seen during movement. Comparing pain scores, the 50 and the 100 microgram, the 50 versus the 100 and the 150 microgram group had comparable pain scores across treatment groups, while the 50 microgram group had significant higher pain scores across treatment groups. For the incidence of tramadol, 30% or 6 out of 10 among the 50 microgram group had the need for the tramadol, while 100 and the 150 microgram group had no need for tramadol demand. For nausea, comparisons across group showed no significant difference. For vomiting, no significant difference was seen across groups, while for pruritus, the 150 microgram group showed the highest incidence of pruritus across treatment groups, while the 50 and the 100 microgram group showed no significant difference. So, according to previous studies, the ED90 for the intrathecal morphine is at 150 micrograms, while other studies states that the 50 microgram intrathecal morphine is similar to that of 100 and 150 micrograms. In another study, a ceiling effect of doses greater than 75 micrograms was noted, and this study also concluded that little justification there is little justification with use of greater than 100 microgram of intrathecal morphine. This study somehow agrees with the last statements. According to our results, pain scores were higher with the 50 microgram group, while no significant difference was seen between the 100 versus the 150 microgram group. In our study, the incidence of tramadol use was recorded for clinical significance with a median pain score of less than 2. The 100 and the 150 microgram group did not need any tramadol demand, while the 30% of the 50 microgram group required tramadol for pain. Hence, in our study, a dose of 100 microgram of intrathecal morphine is sufficient to provide adequate analgesia for post-cesarean delivery. Moving on to side effects, again, different studies differ in results. In one study, they say that pruritus, nausea, and vomiting increases with increasing dose of morphine, while in another study, while there is a proportional trend with pruritus, nausea, and vomiting is not significantly different across treatment and control groups. In our study, there is no significant difference with nausea and vomiting, as mentioned by the previous study. This may be secondary to a pregnancy inherent characteristic of an increase in progesterone level, causing smooth muscle relaxation, a lower esophageal sphincter tone, and a decreased gastric motility. Pruritus was highest in the 150 microgram group, while the 50 and the 100 microgram group had comparable results. This may be secondary to the activation of the mu receptors in our trigeminal nerve by a certain morphine dose. Hence, for the conclusion of our study, a 100 microgram intrathecal morphine is adequately gives analgesia for post-cesarean patients with the least side effects. Thank you.
How was your blinding done on your patients? Blinding.
The main anesthesiologist, the patient, the clinical care team, and the investigators were blinded to the treatment group. Also, the study personnel retrieving the pain scores for the patients were also blinded to the treatment group.
Were you able to record the time of the first request for the analgesia?
Yes, I was able to record the time for the request of the analgesia.
Was there a record there?
No, there was no record included in my final paper, since my objectives only focused on the incidence of the tramadol use.
So again, what is your objective and your sample size determination?
My objective was to determine the least, the adequate or the dose that will provide the adequate analgesia on post-cesarean patients with the least side effects.